Good morning to everyone. Today we will start impression theories and the techniques in the complete danger fabrication. This is a new topic. Actually, we have to finish that remaining part of the mouth preparation in complete danger also. We will finish in the remaining lectures that topic, in which mainly we have to cover that surgical methods in pre-prosthetic surgeries mainly. That is, in gross, we have to discuss that part in the mouth preparation in C. But today we have to start a fresh topic that is impression techniques mean in public dentures. Then first coming to terminologies. What do you mean by the impression? It is defined as an imprint or negative likeness of the teeth or edentulous areas where the teeth have been removed or both made in plastic material that becomes relatively hard or set while in contact with these tissues. This definition is according to the Winkler, and according to Boucher's, the definition is an impression is a record of negative form of the tissues of oral cavity that make up the basal sheet of the denture. Negative likeness or copy in reverse of an object, an imprint of the teeth and adjacent structures for use in dentistry. This definition is according to the GPT 8. What do you mean by GPT? GPT is a glossary of prosthodontic terms. Glossary of prosthodontic terms, and 8 is the edition. You need to denote the edition of that. What are the basic requirements? The knowledge of the oral anatomy, knowledge of the reliable and basic technique, the knowledge and understanding of material, skill, and patient management. The complete denture impression is a negative registration of entire denture bearing, stabilizing, and border seal areas present in the edentulous mouth. The impression in complete denture is of two types mainly: primary impression, which is also known as the preliminary impression, and final impression. The preliminary impression is an impression made for purpose of diagnosis or for construction of a tray. Final impression is an impression for making the master cast. Master cast are used for the construction of the denture. Means satisfactory viscosity, easy to use, adequate working and setting time, can be disinfected, compatible with the dye and cast material, adequate shelf life, and cost effective. These are the desirable features of an impression material. That is, it should have the satisfactory viscosity. It should be easy to use, adequate working and setting time. It can be disinfected, compatible with the dye or cast material. It should have adequate shelf life and cost effective. Evaluating and impression. Impression material homogeneously mixed. The material uniformly distributed in and supported by the tray. Multi-viscosity material blend and adhere to each other. No major defects visible. Fine details clearly recorded. Then no white tears or creases in critical area, and impression adheres to the tray. These are the evaluating factors in an impression. The sources of impression: distortion, anatomical irregularities in mouth like tori, patient having the strong tongue, patient with retained wisdom teeth. These are the sources of impression distortion. Now coming to principles of impression making. Uh, there are the preservation of the alveolar ridge and the health of the oral tissues, then cover of much supporting area as possible, apply the pressure within the physiological limit of the tissues. Problems which we will face are the inflammation of the oral mucosa, medical and surgical correction, then soft resin liner can be given in the treatment of that inflammation, or denture out of mouth for 24 hours before the impression. The problem is mainly inflammation of the oral tissue. For that treatment, we should have the medical and surgical correction, soft liner, and then a low denture out of the mouth for 24 to 48 hours before the impression. Then distorting of the denture foundation. Old dentures might displace the tissues. Excess hyperplastic tissue, finger uh, massage or surgical correction can be given for the excess hyperplastic tissue. So apparent ridge size can be reduced to a real ridge size. Then next problem is the insufficient space between the ridges, the tuberosity, teacher, surgical correction, and the time of healing provided. The second is the support. Support is the resistance of a denture to a vertical components of the mastication and to occlusal or other forces applied in the direction toward the basal seat, provided by the maxillary and mandibular alveolar bones and covering of the mucosal tissue. Is enhanced by placing pressure selectively in harmony with the resiliency of the tissues and using maximum coverage within the normal functional limits. Then coming to next principle, that is the retention, is the resistance of the denture to removal in the direction opposite to that of its insertion. What do you mean by retention? It is the resistance of the denture to removal in the direction opposite to that of its insertion. Then retention resists adhesiveness of the food, force of the gravity, and the forces causing the opening of the jaws. Then factors, that is the adhesion, cohesion, we will discuss one by one. What do you mean by adhesion? It acts when the saliva stick to the denture base and mucous membrane. Cohesion is a The second factor is cohesion, and third factor is the interfacial surface tension, which combines action of the adhesion and cohesion similar to capillary action. We will see these factors one by one in next slides. Then fourth factor is the mechanical locking into the undercuts. Then fifth, peripheral seal, and sixth is the atmospheric pressure. The fourth principle is the stability. The quality of the denture being firm, steady, and constant in the position when forces are applied to it, mainly horizontal forces. The factors are good retention, occlusion, teeth arrangement in the neutral zone window, then occlusion plane, and muscle control. The fifth principle is the aesthetic. The buccal frame should contact mucobuccal fold when tissue relaxed. Should fulfill or should fill the space disturbable to the tuberosity, relieve buccal frenum, adjacent labial flange of the lip extension. Then retromolar pad must be covered, not at the disturbable margin to the relief for masseter. Now coming to the main part, that is the impression techniques. The techniques are classified as the first according to the amount of pressure used. This is the main important part of this topic. That is the techniques used in the impression making. We'll see it one by one. That is first according to the amount of pressure. That means how we pressurize that tissue while recording the impression. The first one is the pressure technique based on the mucocompressive theory. Second one is the minimal pressure technique based on the mucostatic theory. And third one is the selective pressure technique, that is the based on selective pressure theory. Then coming to second, open mouth and closed mouth. Third, hand manipulation, functional movements. Number four, depending on the type of tray, that is stock tray or custom tray or special tray. In stock tray, the edentulous rim lock tray are used. Microwave sprinkler trays are used. Stock trays are used. In custom tray, salad tray, resin tray, like the composite resin tray are used. The selective pressure technique, in which the primary stress bearing areas, uh, that is the in maxilla, These are the crest, horizontal plate of the palatine bone. In mandible, buccal shelf area is there. Secondary stress bearing area, in which in maxilla, rugae area, all ridge slopes are there. In mandible, retromolar pad and ridge slopes are there. This is the maxillary cast, you can see. First, the primary stress bearing area, as we can see the crest and horizontal plate of the palatine bone, and then mandible buccal shelf area. This is the crest, you can see here, and this is horizontal plates. You can see. This is the primary stress bearing area. While in mandible, this area is the primary stress bearing area, buccal shelf area. You can see this. While the secondary stress bearing area is the rugae area and all ridge slopes. This is the rugae area, as you can see. Mandibular ridge slopes and the retromolar padding. This you can see. Then coming to relief area, incisu papilla, mid-palatine raphe, and the crest of the mandibular ridge. These are the relief area present in the maxillary and mandibular ridges. The uses of custom trays constructed with the less relief in the primary stress-bearing areas and greater relief in the non-bearing areas. In this cast, you can see here you can provide the relief. You can see relief is provided in this area. And here, these are the stress-bearing area. That's why relief is not provided. Here, same you can see. Here, this is the primary stress-bearing area in the mandibular ridge. Now coming to open mouth technique, the impressions are made with the trays that is held by the dentist. Mouth is open wide enough to insert the tray. And the advantages are the operator can visualize whether muscle streaming is done properly or not. This is the main advantage of open mouth technique. That is, mouth is open wide enough to insert the tray, and impressions are made with the tray that is held by the dentist. So, dentist is or operator can visualize whether muscle streaming is done properly. That is, the muscle movement is done properly or not. This can be seen by the operator or dentist in the open mouth technique. That this is the main advantage of this open mouth technique. Here you can see, which is most widely used technique in dentistry. Here you can see the dentist is holding the tray in the patient's mouth. Then closed mouth technique. Here the supporting tissues are recorded in functional form. That is, patient is closing the mouth. Then wax occlusal rings made on the primary cast. Then vertical dimension is established before making the impression. As patient is taking that impression himself, that is by closing the mouth. So vertical dimension should be established before the making the impression. And the occlusal rings placed in the mouth and bottom molding and final impression made by the functional movement. All impression is made by the functional movement of the patient himself. Hand manipulation. That is a contour of the denture borders are obtained with use of manual manipulation of the lips, cheeks in the functional lips. The patient's tongue movement required lingual borders. This you can see here. Patient tongue movement records the lingual borders, and while the uh, cheeks and lips in the functional limits. While the contour of the denture borders are obtained with the use of manual manipulation of the lips and cheeks. As you can see in this picture. And coming to next technique, that is the functional movement technique, in which the denture borders formed by having the patient make functional or physiologic movements like the swallowing and sucking. The disadvantages are all patients cannot mold impression compound as needed, cannot be routinely used. Now coming to most important part, that is the steps in the impression making. Selective pressure, open mouth, hand manipulation technique with some functional movements. Preliminary examination, diagnosis, and treatment planning is done first. Then condition of patient is seen. Then oral lesions and their causes must be treated. Where you can see any find out any oral lesions are present or not there. Then sitting of the patient upright with head in line with the body. This is the most important part the student should know, that is the sitting of the patient. Patient should sit upright with the head in the line with the body. Head not bent backwards from the neck. This is the most important point, that is the sitting of the patient. Then operator position, that is the lower front and the on right side and upper on the right side and little behind the patient. This is the operator position. First you have to remember the sitting of the patient and then operator position. In this picture you can see in the next slide. For lower impression, the patient's mouth should be at the level of operator's shoulder. For lower impression, you can see in this picture the patient's mouth. This mouth should be at the shoulder, at the level of the operator's shoulder. Here you can see the operator's shoulder. Patient's mouth should be at the shoulder level. Then for upper impression, patient's mouth at the level of the operator's resting elbow. Operator's resting elbow. Patient's mouth at the level of with the operator resting elbow on chair tilted back little. In this picture, selection of impression tray. Idential stock tray approximately 5 larger than the outside surface of the ridge. This you can see, these are the impression trays. It should be approximately 5 larger than the outside surface of the ridge. Suppose this is the ridge, then this tray should be 5 larger. This 5 is mainly for the, that space is for the impression material. Then you can see one by one. First the tray is selected, then the tray checked in the mount for proper fitting, a proper space is there. This point are evaluated. Then selection of the impression material. High viscosity impression material should be used. Most suitable alternate or impression compound. It is the selection of impression material is a mainly different topic, which should be discussed in detail and it should be discussed in the next lectures. But till the time you should remember that high viscosity materials should be used. Most suitable materials are the alternate and impression compound. Then making preliminary impression using compound impression cake softened in the hot water at the 60 to 65 degrees Celsius. Then loading, you can see, as we have taken the demonstration of the impression compound few days back. For your batch, we will repeatedly take that demonstration of the impression compound only. In this picture, you can see the impression compound is needed and which is loaded over the impression tray. And here you can see the proper loading of the impression compound. Then recording of the maxillary impression. Mouth open, upper legs elevated, and the tray is carried upward anteriorly in the position with the labial frenum as a guide. Then index finger in the first, you can see here. Add up to the triangle with the finger. Then patient mouth open halfway and tray rotated in the until centered over the reach with the tongue raised, seated gently and borders are molded. The preliminary impression using the alternate indicated in the severe undercut ranges, recent extractions and fabrication. Then coming to border molding, which is defined as the, according to GPT, the shaping of the borders areas of an impression material by functional or manual manipulation of the soft tissues adjacent to the borders to duplicate the contour and size of the vestibule. The maxillary border molding in the stick modeling compound added in the section, then heated, tempered with the hot water and molded in the mouth. Tray removed and put in the hot water. The movements are anterior movements are of the upper lip, outward, downwards, inwards. These are the mostly movements given. That is first, the lips are moved in the outward direction, then downward direction, then inward direction. As you can see, this is the outward direction, this is downward direction, and this is inward direction. Outward, downward, inward. The corbuckle phenomenon, the cheek elevated and pulled outward, downward, and inward. And one more movements are added here are backwards and forwards for the recording of the buccal phenomenon. Same movements are there. This is down, outward, downward, inward, and forward and backward movements are added here. The distal end of the buccal flange, place the compound on the side of the tray and patient is directed to move the jaw side to side. The green stick compound placed on the impression tray over the vibrating line and seated in the mouth. Raised strip across the distal end of the impression. The mandibular molding, same lift the lip outward, upward, and in. Same outward. Here for mandible, just use the movement of upward instead of down. Same buccal phenomenon, upward, inward, backward, and forward movement. For masseteric muscle activity, patient exerts closing forces and downward pressure exerts by the dentist. Then anterior lingual flange, protrude the tongue for length. Then distal end of the lingual flange, ask the patient to protrude the tongue, which elevates the superior constrictor muscle and which supports the retromyloid curtain area. To record the effect of the medial trigger on the retromyloid curtain, patient is asked to close and apply the downward force. One step border molding advantages are no number of insertion of the tray reduced. Errors in the developing all borders simultaneously. The polyether impression material used, which is good consistency, sufficient working time, adequate flow. The procedures are adhesive of the impression placed on the borders. Polyether material mixed and introduced in the plastic syringe. Material syringe around the borders and across PPS and perhaps with the fingers moistened in the cold water, trays placed and water molding movements are carried. This is the retention uh, test factory, that is the maximum moderate pressure on the handle and pull the vertically downwards as to patient the wide. This is the retention test for maxillary arch, that is the moderate pressure on the handle is given and pull of vertical downwards movement is given and ask patient to open the wide or mandibular arch, protrude tongue if lifts means overextended. Protrude the tongue and if it lifts then it means it is overextended. Making the final impression, just making the final impression, correct placement of the tray, frenum to be positioned in the notch, and index finger of the each hand shifted to the molar region. This is the part mainly which will be covered in the bottom molding area and impression making area. Just we have covered today the impression techniques. This part will be covered detail in the uh, next lectures. Here you can see the border molding and the importance is given. which will be covered in detail for you in the next technique. Today we have seen mainly the impression techniques, in which if we go through in detail in revision, the techniques are mainly, you can see, according to the amount of pressure used, that is the pressure technique, minimal pressure technique, and selective pressure technique. Pressure technique is also known as mucocompressive. Minimal pressure is also known as mucostatic. Selective pressure technique is, which is based on the selective pressure technique. Then open mouth and closed mouth, hand manipulation, functional movements, and depending on the type of tray used, the stock tray and custom tray or special tray. In stock tray, Edinchulus rimlock trays are used and McGowan Winkler tray are used and stock metal trays are used. In custom tray, shellac and acrylic resin. Shellac trays are used, acrylic resin tray are used, and light pure composite resin trays are used. These are the main techniques we have discussed. Then selective pressure technique, in which the stress bearing area and relief area are discussed. In stress bearing area, just remember crest and the horizontal plate of the palatine bone is the primary stress bearing area in maxillary arch, while the buccal self in the mandibular arch. While secondary stress bearing area in maxillary arch, ruby area is the secondary stress bearing area. Are all ridge slopes are the secondary stress bearing area, while the retromolar pad and the ridge slopes are the secondary stress bearing area in the mandibular arch. This picture. Then we have seen the relief area, which means the incisive papilla is the relief area, and mid-palatine raphe is the relief area in maxillary arch, while the crest of the mandibular ridge is the relief area in the mandible. That's all.